Any other comment? Yes. This great case. Thank you, Peter, for your comment. Thank you very much.
Is there any place in using rotoablation for instant restenosis to debulk instant restenosis?
You want to take the question? Or?
I think for instant restenosis, as you know, there has been a lot of trials and a lot of attempts to treat it with so many devices. Rotoablation was one of them, and it did not prove that it caused any advantages. Similarly, some people have used laser and did not pan out. As you know, the only two strategies that had positive long-term results was brachytherapy.
This live in the box.
And now drug-eluting stents for instant restenosis. But rotoablation per se for ISR is not definitely not been.
That's true. Well, we try in the past with the rotablator, with laser, in order to try to improve the result of, for instant restenosis, but there is no major thing. It's the same for the cutting balloon. And the cutting balloon, the only advantage is the balloon is more stable in the stent, because very many times the stent is slipping upstream or downstream to the stent. The balloon is slipping downstream to the stent. With the cutting, the balloon is more stable. But concerning the result, in particular long-term result, there is no particular significant difference.
John, yes. I noticed that Martin, when he was doing the high-pressure balloon inflation,
yeah.
I mean, if people have observed that, I mean, he went up and then he stayed up for some time.
Yes.
I mean, there is a lot of practice today that you go up and down.
Yeah.
You know, and I think keeping the balloon up for a few seconds, like 10, 15 seconds, is probably you give the balloon time to really inflate, yeah. Especially at high pressure.
And this is an important point, particularly for the people who are doing, direct stenting without predilatation, and sometimes without post-dilatation, just placing the stent and that's it. When you do this, it can be done, but really we have to be sure that your stent is correctly delivered. That is to say, you have to inflate the balloon and keep the pressure up at high pressure for at least 15 seconds. If not, there will be the possibility to have a malapposition of the stent, inadequate position of the stent, particularly if you use long stent. When I think that this is a policy, when you have implanting a long stent, more than 24 millimeter, 28 to 30, 32, depends on the category of the stent. We have 38 with the taxi stent. Really, we must do post-dilatation from the distality to the proximal with a small balloon, higher pressure, and take the time to deliver. Any comment? Galal.
There is a lesion in the LED distal
yes.
to the second. Do you leave it like this?
Yes, absolutely. Yeah.
Because it will decrease the flow, and this may initiate proximal thrombosis.
No, not necessarily. Not necessarily. But we didn't touch this lesion, and we can leave. If not, we move to the full metal jacket of the vessel, and we know that this is not working, definitely. The risk of stent thrombosis is higher. The risk of restenosis is higher. So I think that, and this is the difficulty. The difficulty is to sometimes to say, now we stop, and we try to avoid to place multiple stenting. And this is a good, I think, comment to move to the next case. And you will see the next case, it's totally different case. It's not a problem of complex lesion to do, but it's a problem of really a philosophy of PCI, new philosophy of stenting, based on the functional assessment and not what we have learned since 25 years, just the angiographic image of the vessel. Any comment? Yes, sorry.
I want to go back to the beginning of the case.
Yes.
Okay, so this patient, my understanding, he wasn't have any ischemic pain. He just presented with pulmonary edema.
Yeah.
Okay,
That's true.
and we don't know if this is due to his coronary artery disease or due to his atrial fibrillation, given that the fact that his ejection fraction is with almost 55. So we were talking about bypass surgery, talking about PCI. We end up doing PCI for 2 vessels. And with his renal impairment, we are putting him in antiplatelet therapy, anticoagulant. We know a patient with renal impairment, they have higher risk of bleeding compared to the others. So is there any rule of medical therapy for this patient? And was there any functional assessment, like non-invasive testing, to see if there is a lot of ischemic burden coming from the LAD lesion?
I'm really happy for this question. I'm really happy because many times we are played showing cases in the, in the interventional cardiologist auditorium, etc. And sometimes we forget really the basis of the case, what is indication. And it is true. And fortunately, I cannot show you the slide, but I have some slide showing that coming from the Courage trial, etc., we have not, in this case, objective sign of ischemia. Absolutely no. What you say, the only point is patient who had pulmonary edema. Pulmonary edema, he has coronary angiography, free vessel disease, what to do? But we have absolutely no sign, objective sign of ischemia. By scintigraphy, by stress echo, by what you want. We know that ejection fraction is 55%, which is not too bad, it's not 30%. And he has free vessel disease. And so what to do? And it's true that because he is 82 years old, we try to minimize the number. But exactly imagine the same clinical history in a patient of 60 or 65 years old. It should be different. I think we need to have an objective sign of ischemia and know exactly what are the zone of myocardium which are ischemic, and this is very important. And if you have some hypokinesia somewhere, you have to know exactly what is the viability of myocardium assessed by MRI. I'm absolutely follow you in this way, absolutely. The clinical history of this patient is very poor. But this is a reality. We don't want to, manipulate. These are the data. He has 82 years old, he had pulmonary edema, he had coronary angiography, and we take the decision. Is it enough to take the decision for bypass surgery, for PCI, 1, 2, 3, extent, or what you say, maybe medical therapy in first time, and then we will see the patient under medical therapy? I'm really happy for this question because
John,
this
can I
was
add
one of
to answer this question? I think I can agree with you if this patient has no normal function. The presence of normal function, good function with a 3-vessel disease favor that this patient has severe ischemia. And this severe ischemia is producing angina, and that's why you have to do complete revasc, not only the right, not only the CX, not only the left. Because they have a critical lesion. If you revise the causes of pulmonary edema in 82 years old, it's not hypertensive, there's no evidence of pulmonary embolizations, there's no valvular disease in such patients. So this is an elderly 82 with 3-vessel disease, just septal hypertrophy 82-1, it's not HOCM, it's not like HOCM, it's 21, maybe something that asymmetrical septal hypertrophy of the elderly. So if you revise yourself, I know I agree that you should do it like this for legal, but this patient has acute pulmonary edema in the hospital, and you have to do something with these patients. You have to recover the pulmonary. If this patient going in, for example, in ventilators, so what you're going to do, the vitamin echo, or going to do revasc for this patient to off ventilator this. So I think, I agree with them that they did the best, but the only difficulty with this patient, I think, the calcification at the anatomical and the commodin and the long term, this is the main disadvantage. If you don't have calcification, so are you going to send this patient for cabbage or not in Qatar or Saudi or in Egypt?
I was just playing the devil advocate here.
That's interesting.
Yeah.
And that's all interesting, but
But what I want, I mean, this guy is hypertensive and could have diastolic dysfunction, end up in pulmonary edema. He's also have a history of atrial fibrillation and could end up in pulmonary edema. So there could be other explanation for the pulmonary edema. And we don't have any objective evidence of ischemia.
Your best evidence that it was not if you treat this and he has still pulmonary edema next day.
I have one other, I think probably is the last question regarding the previous case. And this is a question to my colleagues here. I mean, in cath labs where they have rotablations, and it's not uncommon that there will be one individual, two who are used rotablation, the rest don't. And this may be a colleague of you who does not use rotablation commonly, and he started to balloon this lesion and he had the dissection, a limited dissection with no flow limitation, and then he went on to stenting. He would not be able to deliver the stent. And then asks you or anybody else who uses the rotablation, can you help? And was there any role of rotablating a limited dissection, calcified lesion, this to facilitate the delivery of the stent?
Yeah, this is difficult. That is, to be honest, I have done some case of rotablator because the lesion was not crossable by the balloon, and there was a dissection, and I did it. But I think that this is not the best option. That is, say, if the patient is hemodynamically stable, it's better to leave it under full medical therapy, double antiplatelet therapy regimen, and come back, take the patient back on the table a few weeks later. I think it's better because there will be some fibrosis and some healing of the dissection. Of course, if there is no hemodynamic problem. If you have a hemodynamic problem, you have to solve the situation emergency, but you have to know that you take the risk. You take the risk to have a spiral dissection, really hold the vessel, or worst, the perforation. So maybe we can move to the second case. So different case. It's not technical point, but really interesting for the reasoning, and some surprise at the end. We are really pleased to have today with us Martin Thomas from London. We will work with my partner Bruno Farah for this case. Let me introduce all the team around the patient. Our cardiac anesthetist Madi. We have three nurses, Veronique, Laurence and Sylvie. And our fellow on my right, we will present the cases, the clinical history of the patient, Jean-François.
So this patient is a 73 years old male with risk factor as former smoking status, hypertension, diabetes, and slightly overweight. In his past medical history, the patient has peripheral vascular disease with a left carotid endarterectomy in 2007. He's an active man. This patient presents in November with a prolonged angina at rest. Clinical examination in baseline was normal. Also, the ECG was normal. However, in the biology, we can see an elevation of the troponin at 0.11 nanogram per milliliter and a decrease in the renal function with a clearance at 53 milliliter.